and we'll jump right in. So, as many of you may or may not know, pulmonary hypertension is actually a disease that we diagnose on right heart catheterization. But what it is essentially is high blood pressure, particularly in the pulmonary vasculature. Okay, it's really isolated from the systemic vasculature, the normal hypertension that we're used to talking about with the cuff on our arm. It's different. This is a disease of the pulmonary vessels themselves. And as you can see here, I hope you can see my mouse, but the picture on the left is showing you these diseased vessels compared to these very nice open vessels in a normal lung on the right. And you can imagine that over time, if these vessels become progressively diseased, pressures will go up, the pulmonary vascular resistance will go up, and this will lead to sort of what I say a clog in the plumbing system, where blood cannot move forward through the lung, and instead we are left with more right heart failure, okay? So this is particularly a disease of the right heart once it progresses. And the purest definition of pulmonary hypertension is a mean pulmonary artery pressure of greater than 25, okay? You have to meet that criteria to be diagnosed with that disease. And in my world, in sort of the developed world, the most common cause is a disease of the most common diseases that we have. So things like left heart failure can lead to pulmonary hypertension just based on the fact that if your left heart's not pumping blood forward, it'll back up into the lung and proceed to right heart failure. And then hypoxic lung disease, we obviously see in the United States a lot of COPD, or chronic obstructive pulmonary disease, due to smoking. And so hypoxia and CO2 retention, but particularly hypoxia, tends to cause pulmonary vessels to clamp down, and it tends to cause the pressures in the lung to go up. So those are the two most common, the disease processes associated with pulmonary hypertension. Primary pulmonary arterial hypertension, or what used to be called primary, is a disease of the vessels themselves, where they just, for whatever reason or due to whatever risk factor, develop a pulmonary vasculopathy. And this is the sort of rarer form of the disease. But what's terrible about it is that it's still to this day very progressive and incurable. Even at the best centers today, the disease ends in a survival rate of only 65 to 70% at 5 years. And it's a disease that unfortunately can affect young females more than males, although everybody is affected, but females of reproductive age can develop this disease. And I always say it's sort of likening it to a cancer diagnosis because of this poor survival rate. Worldwide, I have to remind myself, although I don't see it very often, schistosomiasis can cause, and is very well known to cause, pulmonary arterial hypertension. And it might be, although we don't have the numbers, I'm sure it's underreported, it might be the most prevalent cause of group 1 pulmonary arterial hypertension in the world. And so every 5 years or so, experts in our field get together in beautiful places like this picture here in Nice, France, and they discuss the classification of the disease of pulmonary hypertension to sort of reclassify based on the most current research going on. And so this was the most recent iteration in 2013. And so you can see these are the 5 different classes of pulmonary hypertension, okay? And the first class here is the one that I talked about, is sort of the purest form of the pulmonary vasculopathy form, which I'll get to in a little bit. And that's called pulmonary arterial hypertension. It is actually a disease of the precapillary arterioles in the lung themselves. And you can see that this class is associated with a whole host of other diseases. HIV, for example, has a 0.5% prevalence within that population. And we're very cautious to check everybody for HIV serologies when we meet them with suspected pulmonary hypertension. Portal hypertension, so anything affecting the liver, can actually go on to develop high pressures in the lung. If you're born with certain congenital heart disease, this can be associated. I mentioned schistosomiasis. We see a lot of, unfortunately, drug and toxins-induced pulmonary hypertension. And I'll tell you a little bit about what drugs and toxins are typically associated. And then there's a familial form. You can see some of these genes at the top here that are related. And familial PAH tends to do worse than others. So you can see that, you know, even what ties all of these very varied disease processes together is the pathology. It's a vasculopathy of the vessels themselves. Group 2 is pulmonary hypertension due to left heart disease. So that's what I mentioned is very common here. Left heart failure, valvular disease on the left side leading to high pressures in the lung. Group 3 is called pulmonary hypertension related to lung diseases or hypoxia. So if you're hypoxic for whatever reason, interstitial lung disease, COPD, if you have sleep disordered breathing and are repeatedly hypoxic in the night. So we always screen very carefully for these diseases as well. And group 4 is chronic thromboembolic pulmonary hypertension. So obviously if you have a tendency to form blood clots in the lung, that can lead to high pressures. And group 5 is sort of a smattering of various other diseases, which we won't spend too much time on. But the most important reason why we spend so much time sort of phenotyping patients when we meet them is because not only do we want to know potentially or identify other associated diseases that we should know about and should potentially treat, like HIV, we also are able to use this information to prognosticate. So you can see here at the bottom, if we take the idiopathic pulmonary arterial hypertension, this IPAH is sort of our baseline group. And so this is a group that we see often affecting young females. We don't really have an associated disease. They're just unfortunate enough to develop it. And that's our baseline. And here's our survival of about, this is a little bit lower than we see today, but 60 to 70%, let's say. We know that patients with connective tissue diseases or HIV, for whatever reason, holding all the other factors constant, tend to do a lot worse, okay? And so if we meet a patient with scleroderma or lupus-associated connective tissue disease, we tend to treat them very aggressively, okay? Because we know that we don't have as much time with those patients. And this is what we're talking about. So hopefully you guys can see the difference here. This is a normal precapillary arterial in the lung, and you can see how nice and open it is, and it allows blood to flow through freely. And remember, this is where gas exchange starts to take place. So here are the accompanying alveoli, and you can imagine that this is why a diffusing capacity on pulmonary function tests tends to be normal, because there's all this nice, easy flow of gases across this border. And this is the disease that is pulmonary arterial hypertension, okay? So you can see now that this vessel, believe it or not, has become completely obliterated by an overgrowth, if you will, of cells. And all of the layers of the vessel tend to be affected. So you will see neointimal formation on the inside of the vessel. You'll see smooth muscle cell hypertrophy in the muscular level of the vessel. And you will also see the formation of microthrombi, or, obviously if you have turbulent flow through this vessel, clots can easily form. And so you can imagine if this is happening at most of these precapillary arterioles, blood flow is impaired, and it can only go one way but backward into the right heart. Okay, and just so you know, if you ever come across an article about pulmonary arterial hypertension, this lesion is called the plexiform lesion, okay, plexiform arteriopathy. And this is the lesion that connects all of those group 1 diseases that I mentioned in the prior slide. And what ultimately ends up harming our patients is the development over time of right heart failure. okay? And so you can see here, this is sort of a two-chamber view of the echoes that we have. And you can see this is actually the right heart here, which, as you well know, should be a lot smaller typically than the left heart. But here, it's larger. This is all the blood in the right heart, and it's actually causing the septum to bow over into the left heart, okay? So the left heart tends to be functioning perfectly well in this disease process, unless you have group 2 disease, obviously. But if we're talking about PAH, the left heart is not the problem. It's purely the right heart. And over time, because of this pressure, it can actually impact the left heart function by just bowing over like this into the left heart. Okay. I'm not going to spend too much time here. I'm not a researcher, but just so you know, at the endothelial cell level of the pulmonary vasculature and the smooth muscle cell level, these are some of the pathways that have been identified. But what you should just remember is that what the disease does is it leads to an overgrowth of cells. So it's, you know, pro-proliferative pathways, or the inhibition of cell death, or the inhibition of apoptosis, or causing these smooth muscle cells to contract or vasoconstrict. So this is the final common pathway, okay? And so calcium channels are involved. This BMPR2 pathway is involved in the familial form of the disease. If you don't have enough natural pulmonary vasodilators or anti-proliferative agents around, like nitric oxide and prostaglandins in the pulmonary vasculature, if you have a deficiency of those agents, then that'll lead to the same common pathway. And you can see at the bottom right here, again, this normal vessel, which just becomes obliterated by this disease process. So a lot of people, as you can imagine, are continuing to identify further and further these pathways in order to affect further therapies over time. And just a bit of a talk, because I know this probably affects you more than it does me, on schistosomiasis-associated pulmonary hypertension. It's, you know, thought to be affecting, I should say schistosomiasis, the disease, is thought to be affecting at least something on the order of 260 million people worldwide, and 67 million people are sort of given treatment that we know of, and it's very common. What happens, or what we think we've identified is why this affects the lung eventually, is, I don't know if you guys have seen anything like this before, this sort of pathway, but the at the bottom here at step 1, and I'm trying to find my mouse so I can help guide you here, but I think I've lost it for some reason. But at the bottom, step 1, you start with schistosomiasis mansoni, which is sort of the agent that it mostly goes to the lung. I think the hematobium tends to go to the bladder and cause issues with bladder disease and so on. But these eggs sort of like to live on snails in fresh water. And so the snail is determined to be the intermediate host. Keep going upwards to step 3 and 4. The larvae then are sort of born and become infectious and get into the water, and then get into the skin of people who are in or near the water. And they travel up through, you know, the lymphatics, and then end up in the liver, and then eventually go into the gastric system and potentially get sort of aspirated into the lung. And this is how we think that this disease sort of gets up into the lung. The mechanisms as to how this actually induces the formation of these lesions are a little bit curious. We used to think, oh, it's easy. These worms just get lodged into the final common pathway of the pulmonary vasculature, these small precapillary arterioles. Do they just get lodged in there? As you can see, a worm there on the right. However, we think it might be more than that. It might be more than just this thromboembolic phenomena of these worms. It might just be that the inflammation itself, which seems to tie a lot of those group 1 diseases together, induces these plexiform lesions. And then, as you may have remembered, or you may see often, this disease can affect the liver and cause chronic liver disease. And so portal pulmonary hypertension is the third mechanism that we think might be affecting this disease. And so how we treat schistosomiasis, I haven't seen a lot of it, but with the cases I've seen, if serologies are positive and the patient comes from an endemic area, we give them praziquantel, we treat them just to say whatever we can do to reduce the disease burden if there is one in the lung. And then we treat the disease the same as we do our other group 1 PAH patients with treatments that I'll get to.